Thank you.
So my name is Jack Larsen. I am the newest member of the clinical team here at our ETSU Addiction Medicine Fellowship, giving this lecture today on all the stimulants. I was asked to give this lecture. I thought the name was kind of interesting, but why all the stimulants? And so I decided to ask David Bowie, who had an answer for that question. David Bowie, as we know, is a great musician, but struggled with cocaine addiction for most of his life, or most of his performing career, and suffered from cocaine-induced psychosis during several of his tours, and eventually got into alcohol as well, too, and unfortunately died from liver cancer related to that. So sad story, as it frequently goes with many musicians, but I thought it would be interesting to include him in this. Objectives for today: describe the pharmacology of stimulants, potential for misuse, discuss the prevalence. Let me minimize this. You can actually see.
No,
There. Okay. Discuss the prevalence of different stimulants, kinds of stimulants in the US. I have no disclosures. Most of the material from this comes from the ASAM textbook, either the small textbook, The Essentials of Addiction Medicine, or the big one, if you dare to open it, because it is very big. And if not, I've cited it in the actual material. So this is a chart that I wanted to share. This is from the CDC, and it's showing national overdose deaths up until 2021 from both stimulants and with regards to stimulants, and then also with stimulants with regards to opioids. So the blue bars is stimulants of any kind type, and then the yellow line is stimulants in combination with synthetic opioids, particularly fentanyl. And then the gray line is stimulants without any opioids. So this could be a reason also why all the stimulants, why we need to talk about this now and why these are important, is because overdose deaths, unfortunately, are increasing. They appear to be increasing both independently of synthetic opioid use, but also you see the yellow line is going up quite steeply there at the end. They seem to be increasing, particularly in combination with synthetic fentanyl use, and that's, a lot of people have described this as the so-called like fourth wave, and the third wave being fentanyl use, and this is like a fourth wave, people are calling it, with regards to overdose deaths, the combination of synthetic opioids with synthetic stimulants. I threw in this chart as well because it tells you a little bit about characteristics of adults evaluated for substance use treatment planning. Basically, just to give an idea of what exactly we're looking at as far as stimulants and what people are using. Mostly this is in here to make the point that people aren't just using stimulants by themselves, they're frequently using them in combination with other things. You'll see this, the first most common is with regards to stimulants, isn't just stimulants by itself, it's actually people using stimulants with cannabis at the top. And then you go down, alcohol becomes more involved. It seems like alcohol, cannabis, and stimulants, or any one of those combinations, seems to be the most common way stimulants are used. From a more general perspective, stimulants affect dopamine, most affect norepinephrine. Those are neurotransmitters in your central nervous system. There are two basic types of stimulants. There are plant-derived alkaloids, and then there are synthetic stimulants. Plant-derived ones are the kind of ones we traditionally think about, such as cocaine, and then there's newer ones that are synthetically made as well. They work on the central nervous system and on the peripheral nervous system, which is where they primarily activate neurons. They have more addiction liability, just like basically anything, if they're used in such a manner where they're delivered quicker to the brain. That could be IV use, that could be smoking, that they will typically get to the brain faster, work quicker, have more effect, and then have more of an addiction potential. Stimulants have a characteristic rapid decline, crash after you've been using them for several days. You'll see people they tend to crash for a long time. They tend to get very hungry, and this will last a few days, but it's usually just treated symptomatically. The effects of stimulants include increased energy, alertness, sociability. Those are seen as positive effects by people. Elation, euphoria, also positive effects. Depending on what you're using it for, decreased fatigue, need for sleep, and decreased appetite particularly could be effects too. So people that were looking to maybe lose weight might find stimulants to be an attractive substance to use. Also, psychiatrically, stimulants cause a variety of effects, including anxiety, panic attacks, hypervigilance, paranoia, grandiosity, impaired judgment, and psychosis. The acute psychosis related to stimulants can kind of resemble schizophrenia, versus if you've been using stimulants for a prolonged period of time, you can have more chronic psychotic symptoms from stimulants that can last a long time. May not resolve just because somebody stopped using stimulants a few days ago. The psychosis may persist for weeks or months afterwards. The physical effects can include like skin picking, restlessness, agitation, tremors, dyskinesia. I'll frequently see patients with some pretty terrible skin wounds from picking after using methamphetamine. Chronic use of stimulants, just like most substances, but affects your frontal lobe and can cause impaired decision making and cognitive impairment for up to several months after last use. Some of the effects of stimulants on our body from a medical standpoint, from a cardiac standpoint, or cardiovascular standpoint, can cause strokes, heart attacks, cardiac rhythm problems, and sudden death. As far as other effects, you can have effects that are related to the route of administration of the stimulant. So, for example, if you're smoking cocaine, crack cocaine, you could get crack lung. From that, you could have HIV or hepatitis C if you're injecting the stimulant, or nasal septum damage if you're snorting the stimulant. For example, if you were to snort cocaine. Body packing is another way that stimulants can have a toxic effect on the body. So this is typically seen in like drug mules, people who are trying to sneak drugs in, typically through an airport setting, but really any kind of border crossing or anything. They will pack the drugs, hopefully in something that is perforation proof, but not always. They can use condoms, or a variety of other mechanisms have been employed. But if that packaging would happen to be ruptured, you can get things like gastric ulceration, perforation, and ischemic colitis from stimulants. Rhabdomyolysis is commonly seen. Dental problems, you see on the right a picture of the infamous meth mouth is there. It reduces your libido, impairs sexual function, which can be in some instances desired. If that's something, if you're having erectile dysfunction or inhibited ejaculation, that could make you have sex for longer. So that, combined with the euphoria, kind of lends itself to stimulants being used in sexual encounters. Even though they reduce your libido, they impair your sexual function. For some people, that can be desirable. Memory and language deficits are seen after in utero exposure to stimulants. And then in breast milk fed infants whose mothers are using stimulants, you can have irritability, sleep disturbances, and tremors. As far as stimulant withdrawal, we talked about kind of the typical crash symptoms: depressed mood, anhedonia, fatigue, difficulty concentrating, increased sleep, and then increased appetite. So I've heard stories of people in detoxes for residential programs where they'll crash off stimulants, and they literally just have bowls of candy out in the common room. People will just eat. And part of that is because of this appetite. They've had their appetite suppressed for so long. And the other part of it is because people are looking for any kind of dopamine, right? And if they can get just a little bit of dopamine off something, something sweet when they're withdrawing, then they'll go for it. So we do see that typically in both in detox and in rehab settings as well. A general overview of cocaine is the first stimulant we're going to talk about. Cocaine is a tropane ester. It is found naturally in the leaves of the cocoa bush, Erythroxylon cocoa, where it is an insecticide, kind of like caffeine or nicotine. It's found naturally as an insecticide. Of course, us humans take it and make it something else entirely. It's been naturally chewed there by people living in South America, particularly in the Andes mountain region, for a very long time. But more recently, Europeans figured out how to essentially isolate the salt drug out of the leaf of the cocoa bush. We have found that heating destroys the drug. So if you try to take purified salt cocaine and smoke it, it won't work. It'll kind of just degrade. But if you add bicarbonate and heat, you can turn it into a base. That base has a lower melting point and can be smoked, aka crack cocaine. So that's why freebasing cocaine will enable you to smoke it. These are the areas where cocaine is primarily grown. You see the majority is in Colombia, but also some in Peru and Bolivia. It is legal in those areas for domestic oral use of chewing up the leaves, but not to purify it or sell it on any large scale. This is kind of the history of cocaine in the United States. Started off in the late 1800s, was mostly used for all kinds of things. You can see it was used in Coca-Cola as an intellectual beverage and temperance drink. Marketed for all kinds of things. This particular advertisement markets it for headaches, neuralgia, hysteria, and melancholy. They have since removed this from Coca-Cola. You can also see cocaine tooth drops. I love this picture of the nice little children out playing, and one of them had a toothache, so he had to go get some cocaine tooth drops and drops. In the 1914, these were banned from over the counter by the Harrison Narcotic Act. That's by prescription. Sigmund Freud, in his Uber Coca, suggested cocaine as a treatment for morphine addiction. Today, it is still available for clinical use, but is extremely limited. I've never seen it. I have heard of it being used in the setting of nosebleeds by ENTs. But I've never seen it used personally. It is the second most widely used drug in the US and globally, after marijuana. In 2015, about 38 million Americans had used it at some point, so a pretty significant number. You'll see on the graph at the bottom, it tells you kind of global drug use percentage. And this is as of 2016, but people who use different substances, you see cannabis is by far the most common, but the next three are all stimulants. So definitely pretty prevalent as far as stimulants go. I thought this was humorous. It was from our ASAM textbook, so I decided to include it. Data from the 2001 to 2003 National Comorbidity Survey replication suggests that the most likely cocaine user is an unemployed, divorced, separated, non-white, non-Hispanic white male high school dropout or graduate in his 20s living in a non-rural area in the Northeast or West for whom religion is not important. Instead of telling you all the different risk factors, which would be that you are non-Hispanic white male, that you are, of younger age, that you live in an urban area. I thought this was a humorous way of phrasing it. But that is our most likely suspect for a cocaine user. This is a diagram of neurotransmitters involved in cocaine use. So cocaine primarily affects preganglionic neurons, where they're releasing norepinephrine and dopamine. They release it here into the, see, I can point at this, into the synaptic cleft here. They're going to inhibit reuptake of norepinephrine back into this preganglionic neurons. So you get higher concentrations of norepinephrine and higher concentrations of dopamine here in the synaptic cleft. And that'll create more stimulation onto the next neuron. As far as effects from the brain, they are released in the mesocortical limbic system, like we talked about. This includes the ventral tegmental area, the prefrontal cortex, nucleus accumbens, and amygdala. Serotonin and endogenous opioids and glutamate are also involved, but to a lesser extent. Cocaine blocks sodium ion channels, hence its use as a local anesthetic, and causes cardiac arrhythmias. They've also described the effect or the phenomena of speedballing, which is combining cocaine with heroin or other sedatives in order to kind of temper the anxiety, paranoia, and restlessness that go along with cocaine use. Cocaine metabolism is mostly metabolized by carboxyesterases in the liver and eliminated in the urine. Coca-ethylene is something to know for our fellows. Apparently this pops up on board, or at least I've been told this pops up on lots of board exams. This is a byproduct of cocaine and ethanol. So if somebody's both drinking and using cocaine, they may well have coca-ethylene in their urine. I've seen this tested for elsewhere, and it exists. Other stimulants, this is another natural one, would be cat. Comes from the Catha edulis plant. This is popular in East Africa and on the Arabian Peninsula. It contains two stimulants, cathinone and caffeine. Typically, this is used as leaves that are chewed. They can be smoked as well. Usually by farm laborers or day laborers or somebody who's kind of out in the fields using it to using the stimulant effect to help them work. It is not used in the US very much. I haven't seen it personally here. And I believe the reason for this is that it doesn't work after a couple days. It kind of degrades. So unless you can get it here within 2 days or so. So pretty much you'd have to be like overnighting this stuff here to get it to really any effective potential, which I'm sure somebody does, but I haven't seen. There also exist synthetic cathinones that are related to this, but have the human mark on them. And these are things like bath salts that can be misused, or flocka. Ephedra comes from the Ephedraceae, I'm hoping I'm pronouncing that right, plant species, which comes from the Chinese herbal huang, which has been used there for 5,000 years. It's usually obtained by drying young branches of the plant, which are then turned into a capsule, a tincture, liquid extract, or tea. They're frequently marketed as legal versions or legal highs with other stimulants, but they have been banned from US market supplements by the FDA due to having cardiovascular effects and CNS effects. So that's it for the naturally occurring stimulants. We'll move on to synthetics. There are prescription stimulants available as far as synthetic stimulants. Several are FDA approved for indications such as ADHD, narcolepsy, weight loss. This includes amphetamine, which is Adderall, Listex, amphetamine, Vyvanse. Cocaine, we talked about that earlier. That one's not synthetic. Methamphetamine, or Adipex, methylphenidate, Ritalin, modafinil, Provigil, or phentermine. I have not, all of these I have seen, except for I have not seen that amphetamine prescribed, though it technically could be done. Children receiving stimulants for ADHD notably do not have an increased risk of substance use later in life. As far as there are other ones available over the counter, decongestants such as pseudoephedrine. Many of these prescription stimulants are banned by the World Anti-Doping Agency for sports athletes. As far as synthetic amphetamines, they were synthesized in the late 1900s and methamphetamine, or I'm sorry, the late 1800s, and methamphetamine in the early 1900s. Something that was super popular back in like the 30s was benzodrine. Apparently this was available over the counter, essentially amphetamine over the counter. I love this picture of the nice little cherubic girl with her nose essentially up a canister, an inhaler, I'm sorry, of amphetamine, which is being used for head colds, nasal catarrh, which I believe is like sinus congestion. And then amphetamines today has changed quite a bit. In the lower left is a picture of a methamphetamine lab in Mexico. This is primarily where most of the methamphetamine comes from now. You can see there's some great quality control going down. It's basically done under like a thatched roof. In this particular lab. In 2015, almost 15 million Americans had used methamphetamine at some time, and there were over 15,000 stimulant-related deaths from 1999 to 2009. And I imagine with the chart we saw, that is only increasing. This is a great chart because I've never seen another chart that has an axis that tells you the meth labs per county. I thought that was a great scale to use. Now, regardless, most of the methamphetamine is not synthesized here. It's mostly synthesized in Mexico or elsewhere and brought in here. But this does kind of give you an idea of where domestic production is taking place. You can see there's some in Appalachia. And call it a hotspot as much as like it seems like the desert outside of California or LA, which I guess you'd expect. And then right in between Missouri and Illinois, there seems to be a lot of meth lab spots per the DEA. Amphetamines work similarly to cocaine in that they also, this is another diagram of a pre-ganglionic neuron. They're also going to inhibit this norepinephrine reuptake transporter here, but they're also going to have an additional mechanism of action working on presynaptic storage vesicles and releasing norepinephrine that way too. So they kind of have a dual mechanism for releasing norepinephrine and dopamine too. They are metabolized in the liver via deamidation, oxidation, and parahydroxylation, and are eliminated in the urine. As far as drug-drug interactions for amphetamines, there are MAOI inhibitors, which frequently are not very frequently used anymore, and TCAs as well. They can interact with because they block the presynaptic reuptake of catecholamines.